Hi, this is the tutorial on fluid management in children. So the slides were put together by my colleague Dr. Namu. So the rules are very simple. Commonly used rule is this one, 150-20 rule. For example, let's assume the child's 30 kilogram in weight and work out an example for you to write up the maintenance fluid requirement. So the child's 30 kilogram, so you have 3 10 kilos there, 10, 10 and 10. So for the first 10 kilos you would give 100 mils per day, which will equate to 1000 there. So the second 10 kilo would be 50 ml per kilo per day, so that will equate to 500 ml, and anything after that would be 20 ml. So in this situation it will be 200. So you total that up, so that is 1000 plus 500 plus another 200, so that's 1700 in total. So this will be the child's fluid requirement for the whole 24 hours. So the hourly rate would be 1700 divided by 24. So how many ever X amounts of mils per hour. So when you prescribe the fluid, you would write maintenance fluid for this child is 0.45 with 5% dextrose. This is the most commonest fluid which is currently in use, but some units use 0.9% saline, but that doesn't matter. Just check with the unit that you're working what the fluid is, and then you would write 500 ml bag, and then you would write infuse X ml per hour. So that X ml is how much ever you got over there. So hope that's not too confusing. Let's look at another rule now. I personally prefer this rule because it's much more easier to do and gives you the hourly rate rather than the daily rate. So let's work out another example, the same example. Let's say this child is this time, let's say it's 35 kilogram in body weight. So the 4-to-1 rule is, so we have 35 in total, so 10 kilos, 10 kilos, and then there is 15 kilos after that. So 4-to-1 rule would be, for the first 10 kilos you would give 4 ml per hour, so 10 times 4, that's 40. For the second 10 kilos you would give 2 ml per kilo per hour, so that's 20, and then anything after that you would give 1, so that would be 15. So this child's hourly rate would be 40 plus 20 plus 15, that's 75 ml per hour. So you would get exactly the same thing if you do the 150-20 rule, or maybe a couple of mils difference, but that doesn't matter. But essentially you're doing the same thing. I prefer this method because it gives you the hourly rate, so you don't need to get the calculator out to actually do further maths to get the hourly rate. But some people would prefer the 150-20 rule, so it's entirely up to you as to which one you choose. Now let's go on to learn about how to calculate percentage dehydration. So very often we just talked about the maintenance fluid. So this is, for example, if a child is admitted for surgery and needs to go nil by mouth, that's the sort of situation you would write maintenance fluid up for. Now let's assume a child is coming in with dehydration. So how do you calculate percentage dehydration, and how do you sort of correct for dehydration? So let's try and figure this out with a simple example, right? So now you have a child who is 30 kilogram in weight, and you want to find out how much would be 10% dehydration correction, right? Okay, so 10% of 30 would be 3 kilograms. Because we are mostly made up of water, 3 kilograms would be equal to 3 liters of water. 3 liters would be 3000 mils. So this child's deficit, you can say, is 3000 mils. Now that's 3 liter. You're not going to replace it in one go, because remember, your total circulating body blood volume in an adult is only 5 liter. So 5.5 liters. So in a child it will be much less. So you can't be pushing in 3000 mils of saline into the child, because they'll simply go into cardiac failure. So you have to replace it slowly. So you want to replace it over 24 to 48 hours. So if you want to replace it over 48 hours, it will be 3000 divided by 48. So at X amount of ml per hour. So if I say that you got a particular amount, so let's say this was let's say this was 60 ml, for example. So you would want to add 60 ml per hour to the maintenance. So we calculated the maintenance earlier with the 4 to 1 rule. So that will be 40 plus 20 plus 10. So that will be 70 ml. So you want to add 70 plus 60. So the total is 130 ml per hour. So for this child who has got 10% dehydration, you want to correct over 48 hours, you would prescribe 130 ml per hour rather than the maintenance of 70 ml per hour. But the most important thing is not to give the whole dehydration correction quickly and to give it actually slowly. Now, one scenario you have to remember is, for example, this child with 10% dehydration is clinically in shock. You have to get them out of shock. So what you would do is, out of that 3000 mils, you would give a 20 ml per kilo as a bolus. So this child is 30 kilograms times 20. So 600 ml out of this 3000 mils you would give as a bolus. So that's a push. Maybe within 10 or 20 minutes you would push it as quickly as you can. But when you write up the dehydration correction, you need to make sure that you take that 600 mils off before you write up the dehydration correction. So hope that's not too confusing. Let's move on to there is a formula for calculating dehydration. So the formula is as follows. So it's weight in kilograms times percentage dehydration times 10. For example, if you're given a child who is 30 kilogram and you're told that the child's dehydration is let's say 20% dehydration, just for argument's sake. So you would do 30 times dehydration percentage times 10. So that will be your deficit in mils. So that's 30 times 20 is so that's 300, 600, 6000 mils. So which is what you would get if you went by what we discussed earlier as well, right? Okay, but some people find it easier to just remember the formula. It's useful when you're doing odd numbers. For example, if you get a child who is for example 23 kilograms and I ask you to calculate 8% dehydration, in that situation it's easier to know the formula, because you could do simply 23 times 8 times 10, and that will give you the dehydration correction in exact mils. So it's much easier to know the formula when you have complicated numbers like this rather than 5s and 10s. Hope that makes sense. So let's look at some examples just to give you some more practice. So a 7-year-old girl is admitted for elective surgery and is kept nil orally. So her weight is 23 kilograms and height is 115 centimeters. Can you write an order for her IV fluids prior to surgery for 24 hours? So as I said, the first thing you need to know is the weight. And she's simply admitted for surgery, so she's just going nil by mouth, so she's not dehydrated. So we use our 4 to 1 rule. So for the first 10, so we've got 23 kilos, we got 10, 10 and then 3 kilos. So the first 10 kilos will be 40, second is 20, and then you got just 3 kilos after that, so 3. So you got 63 ml per hour. So this is a full maintenance fluid. So you would write up something like this. You would do the date there, then you would do the fluid, which is 0.45 saline with 5% dextrose. As I said, some units might just use saline. and then there will be a box which says additives. This child is just going on for surgery for a brief period of time, so you don't have to put any potassium in it. You could just leave it nil. And now you have to write the volume of the bag. It's usually a 500 ml bag which we use for kids. You could use a liter bag as well. And then there will be a column which says rate on the drug chart. There you would write 63 ml per hour, and you sign and put your bleep number, whatever. Right, so hope that was easy. So let's try another one now. So you have a 2-year-old child who's got a closed head injury and is comatose. Weight is only 14 kilograms. So I think the thing you need to bear in mind in this one is it's a closed head injury. You don't want to give any more fluid than it's absolutely essential. So you don't really want to give full maintenance fluid here. So the main thing is to make sure that we don't give unnecessary amount of fluid, and number 2, you don't use hypotonic fluid, you use isotonic fluid, that is normal saline. So you wouldn't use half saline here, you would use normal saline. So the child is 14 kilograms, so we know our I'm only going to give 2/3 maintenance. So I don't want to give full maintenance because obviously this child's ICP would go up. So we use the, shall we try the 100 50-20 rule this time rather than the 4-2-1, or you could try whichever one you like. So first 10 kilos, that's 1000 mil. The second 10 kilos, you only have 4 kilos in the second 10 kilos, so that's 200 mils. So total is 1200 mils. Sorry, 1200 mils. So I only want to give 2/3, so you do 1200 times 2 by 3. So that many mils per hour, sorry, per day. So let's say in this case you got 2400 divided by 3, so that is 8, so that's 800 ml there. So you want to divide that 800 divided by 24, that will give you the ml per hour, how many ml per hour. So hope that was simple. Fluid, again, choice of fluid is saline, not half saline or any other hypotonic fluid. That's the thing. These are the two things to consider in this child. Right, let's move on to another example now. So there's another question there. How would you differ this child from a child admitted with fever and tachycardia? Obviously, child admitted with fever and tachycardia is in warm shock, so they need more fluid, whereas this one needs less fluid. The choice of fluid could be the same in both. You could use half saline with 5% in a child with fever, but definitely not in a child with a closed head injury. Right, okay. A 10-month-old infant has DNV, has got a bit of fever. So how would you decide the child needs IV fluid or not? That's quite easy because DNV is quite a common thing. You don't want to be sticking needles in and giving IV fluids to all of them. So you want to try fluid challenge. We usually use oral rehydration with something called, the brand name is Diaryl. It's basically oral rehydration solution. You would want to give small amounts frequently. For example, in this child, I would just give 10 ml every 5 minutes or so. The way you work out the maintenance fluid is the same. So you work out the hourly rate and then sort of subdivide into little aliquots and give them a little syringe and ask them to keep a chart of how much the child has drunk. The main thing is to make sure that you keep reassessing the child for signs of deterioration. For example, if the child was not dehydrated at all, you start oral rehydration and things are not working, the child is going on to mild to moderate dehydration or to severe dehydration, obviously you should review your decision and put the child on some IV fluids. So you have to constantly reassess the child. Let's look at another example. A infant weighs 11 kilograms and is estimated to be 10% dehydrated. What's the calculated deficit and how will you replace it? What IV solution should be used? So a couple of things to consider here. So the child is 11 kilogram. So when you're 10% dehydrated, you're likely to be in shock. The child is young. So you would want to give a fluid bolus first. So how much would you give? We normally give 20 ml per kilo fluid bolus. What do we give? We give saline normally. So that will be, so 20 ml per kilo will be 20 times 11. So that will be 220 mils. So you push in quickly through an IV cannula or an intraosseous cannula 220 mils. So you've given that. Now you need to work out the dehydration correction. So let's work out the maintenance first. So what's the maintenance? 11 kilogram child. So we know that the 11 kilogram 4-to-1 rule. So 40 for the first 10 kilos and then this 2 for the second 1 kilos there. So it's 42 ml per hour. So that's your maintenance. Now you have your deficit. So 10% of 11 kilo, that's very easy. So that's 1.1 kilo. So 1.1 kilo will equate to 1100 mils. Yeah. So that 1100 mils, you want to take out that 220 mils which you gave. So that will give you 880 mils. Now you want to replace it, you don't want to give it straight away, you want to replace that deficit over 24 to 48 hours. For example, let's say we're going to do it over 48 hours. So you want to do 880 divided by 48. So you get XML per hour. So you want to add 42 to that X, whatever you get, and then you want to infuse that. So for example, let's for argument's sake say that we got how much would that be roughly? So that'll be, let's say you got 20 mils there. So you want to do 42 plus 20. So that'll be 62 ml an hour. And what fluid would you use? Again, you could use saline or half saline. So you would use 62 ml per hour. You could use saline or half saline, whatever you like or whatever your unit policy says. I don't have any strong feelings about either. Hope that was easy. I think often when you have the electrolytes, it's easier to decide what fluids you want. So what lab test should be ordered in this case? So dehydrated, so obviously use anise, because remember you can have hyponatremic dehydration or hypernatremic dehydration. So the sodium could be up or down, so it could be up or down. So keep an open mind. It doesn't always mean that you have high sodium in kids who are dehydrated. You could have low sodium as well. Urea and creatinine, obviously I would order those to look for renal function. That will help us with deciding the course of treatment as well. So those are the main things. Use anise, sodium, potassium, urea and creatinine. Depending on what the child's admitted with, you could add other things like full blood count. You could use inflammatory markers. We use something called C-reactive protein in children a lot more than ESR. Let's look at another example. A 3-month-old infant is brought to A&E with focal seizures lasting a couple of minutes. He had diarrhea for 3 days and he was mainly being given water and orange juice. So this is quite not a common one, but you see this once or twice a year. So this is very likely to be due to low sodium. So the seizures are likely to be due to low sodium because the child's being mainly rehydrated with water and juice, which is probably low in sodium. So I would definitely check, do a quick blood gas, which can usually give you sodium and potassium in most places. So what might be the cause of seizure and how should they be treated? Now, when you have low sodium, it depends on what the reason for low sodium is. For example, in this case, it's very clear. The child's just been given water. In some other cases, it could be due to SIADH, in which case the treatment would be restricting fluid. In this case, you have to rehydrate with saline or half saline at least to bring the sodium back up. So let's look at another situation here. So this is a 9-month-old child who has got DNV has got moderate dehydration. So sodium is 162. So this is a child with hypernatremic dehydration. Potassium is 5.6, bicarbs 12. So that's quite low bicarb. So that makes me a little bit worried. So the child's probably very dehydrated. So someone's gone on to treat this child, and when the child's being treated, the child has a seizure. Why do you think that's happened? So the most likely reason for this is someone gave some fluid and it came crashing down to, let's say, 140. So the rate of fall was very quick, and this can cause seizure because it causes demyelination. You could pretty much inflict a nasty brain damage if you bring down the sodium too quickly. So this is a situation where you have to use normal saline. If you give half saline or quarter saline, for example 0.18 saline or 0.45 saline, this can come crashing down, and this is probably what has happened. Easy way to remember is, if you have a normal sodium, you give normal saline, it will stay the same. If you have a high sodium, you give normal saline, it will come down slowly. If you have high sodium, you give half saline or quarter saline, the sodium would come down, crashing down, and that will cause brain damage and seizure. And many times the brain damage can be irreversible. So it's a really important thing to bear in mind when you correct hypernatremic dehydration. So we discussed the best treatment is obviously normal saline. We don't generally tend to use hypertonic saline to bring it down, but that's an option, but we don't normally use it. We usually would just use normal saline, and that usually is got high enough concentration to bring down the sodium slowly. So let's look at the next one. Is 11-month-old infant who has got DNV, is a little bit lethargic, has got dry mucous membrane, heart rate's 130, only small amounts of urine passed 6 hours ago. What type of liquid would you recommend that her mum give, and how often? So we could try, so this child is mildly dehydrated. You have dry mucous membrane over here, heart rate is not particularly fast, just a little bit fast, and then you have a bit of urine, but it's tailing off. So this child's got mild dehydration. So you want to correct the dehydration. The fluid you would use is the oral rehydration solution, which is diarrhea. Essentially, it contains sodium, it contains potassium, it contains chlorine, and it contains some sugar. So you have salt and glucose both, and obviously water. So the difference from giving water is that the child will get rehydrated at the same time, or the electrolytes which were lost will be replenished, and the child will have energy to survive. So you have everything you need to survive in the oral rehydration solution. Now how much would you give? So let's say this child is 10 kilogram. So just work out, let's say this child is 10% and is clinically not particularly dehydrated, and you just want to do the maintenance rather than the correction. I would say the 4-to-1 rule here is just 40 ml an hour. If you want to get 40 ml an hour into this child, let's say so this child can have small amounts, every 5 minutes 4 ml or so. That will give you the maintenance. Obviously if the child is a little bit dehydrated, then obviously you factor that in and then give a little bit more to correct that as well. So the rules are very simple. So a 7-year-old boy is diagnosed with diabetes and has the following blood results. So the blood sugar is high as you expect, ketones are high as you expect. So you should think about diabetic ketoacidosis here, because it pretty much fits the criteria. We only need to see a pH. So you have high BM above 15, you have high blood ketones above 3, you have bicarb below 15, and in addition to that, if you have acidosis on a pH, then obviously that gives you a diagnosis of DKA. So what fluid should be used over the course of the DKA management? Now the things to consider in DKA management is The critical thing is to actually give fluid first and insulin afterwards. So always in that order, fluids first and then insulin, not the other way around. So let's say this is a 7-year-old boy. Let's, for argument's sake, say this child is 30 kilogram. So you want to work out, let's say he is 5% dehydrated. So that will be 5% of that. So you know the rules to find out the deficit. So weight times percentage dehydration times 10. So that's 300 times 5, it's 1500. So that's the deficit. So you want to give that over slowly over 24 to 48 hours. So you want to, let's say you want to replace it over 24 hours, so you do divide by 24. If you want to replace it over 48 hours, you divide by 48. Okay. So let's say you want to replace it over 48 hours, so that will be roughly about 30 ml per hour. And then you calculate the maintenance. You know, a 4-to-1 rule here would be 40, 60, 70 ml plus that 30 ml of deficit. So that's your maintenance, it's your deficit. So you have about 100 ml per hour. So you would give 100 ml per hour as maintenance. But what you need to remember is, if you give this child, as soon as the child comes in with DKA, we would give some fluid boluses. So of that 1500 deficit we calculated, the child comes into A&E, let's assume someone has given a 20 ml per kilo bolus. So that will be 30 times 20, 600 ml would have been given already. So when you calculate the deficit, you need to take that 600 out. So you would want to take 600 out, so that gives you 900, and you're only replacing that 900 ml over the next 48 hours. So if we didn't include that, so earlier we calculated that the deficit correction was how much did we say it was? We said it was 30 ml an hour was the deficit correction. Let's see what the new one would be. So this will be roughly 20 ml an hour, not 30 ml an hour. So you can see the difference, and the total fluid would be, that was the maintenance we calculated, so 20 plus 70 will be 90 ml an hour instead of 100 ml an hour. So it's important that we actually take off the boluses we gave, otherwise we'll end up giving too much fluid. Now the other things to remember in DKA correction, diabetic ketoacidosis, is best place to look for the details is BSPED website. If you look on that, British Society of Pediatric Endocrine and Diabetes, if you look on the website, you can find a calculator which is excellent. So you just need to put the weight and the deficit in, and it works out. So it's unlikely to go wrong. So it's best to use the calculator. So the other factors, the general principle you need to remember is, initially when you're giving a bolus to someone in DKA, give saline. Bolus is always saline. Okay. First hour, so you give the bolus and then you start the fluid. So what fluid would you start? So we worked out we're giving 90 ml an hour, but what fluid? Usually the first bag is always normal saline. You can see the potassium is high there. So the potassium was high there, but when you start correcting it, the potassium will start going down. So from the second bag onwards, so add potassium. So start adding potassium. For example, to every liter bag you add 20 millimoles of potassium to every bag. So after the first bag you should start doing that. And then obviously you would start insulin. So how much of insulin would you normally start? So you would start for example, this child's 30 kilograms, so you want to give 30 times 0.1, 3 unit of insulin per hour. So how do you make it up? So you take 50 units of insulin, you put it in a 50 ml syringe. So you get this syringe, you got 50 ml and 50 units in it, so that will be 1 unit per ml. So you infuse 3 ml per hour, that will give you 3 units per hour. Thing to remember is, when the sugar is getting corrected, you can see that the sugar might start coming down rapidly. Do not turn off the insulin, because insulin is extremely important to switch off the ketone production and to come back to normality. So if your sugar is crashing down, add more sugar to your fluid rather than cutting down the insulin. If you're desperate, you could half that to 1.5 units, but usually the best way forward is actually to increase the fluid, sugar and the glucose concentration in your infusion. So hope that's clear. You'll have separate lectures on DKA, which will make things easier for you. So we'll leave DKA alone for the time being. So a 15-month-old child presents with 2-day history of DNV. She's listless and her heart rate is 180. So this is quite worrying actually. So you can see its heart rate's really high, so the child's in shock really. So let's look at what's the most appropriate initial management. Obviously give a fluid bolus. So let's say this child is 10 kilograms, you would give a bolus straight away of 200 mils, and that's usually normal saline, and then you would go on to put a cannula in or an introtious in if you can't get a cannula, reassess after the bolus, give a second bolus if required, and then I would use an ease when you actually put a cannula in. The best way is to actually do a blood gas. Most hospitals these days will have a blood gas machine which will give you sodium and potassium, and that will guide you as to what your maintenance fluid is. As we saw from earlier, a similar situation where a child was given quarter saline and went on to have a seizure. If the sodium is very very high, we should avoid giving quarter and half saline instead. You should use normal saline as your maintenance fluid. So I think that brings us to the end of this lecture. So just to summarize, the things to know are the 100, 50, 20 rule. If you didn't like that, this will give you the fluid maintenance over 24 hours. If you don't like that, you could use the 4 to 1 rule, which will give you the fluid maintenance per hour. This will give you per day. So if you're doing that, then obviously you need to divide it by 24. We learned that the formula to calculate the amount of dehydration is weight times percentage dehydration times 10. So for example, if you have 10% dehydration and a 10 kilo child, will be 10 times 10 times 10, should be 1000 mils. The other things to bear in mind is you need to know that if your sodium is high, you need to bring it down slowly, use normal saline. And then obviously you need to know the important variations. So one is head injury, the other one is DKA. These are quite favorite topics for exams in general. Hope that was useful. Please leave any comments if you think that I could improve it further in any way. Thank you.